Welcome to the podcast of the European Society of Anaesthesiology and Intensive Care. I'm your host, Professor Wolfgang Buhre. I'm a professor of perioperative medicine from the University Medical Center in Utrecht, the Netherlands, and I'm also the current president of our society. And today we will talk about how electronic health records and digitalization can improve outcomes. For me, it's a great pleasure and also a honor to welcome Dr. Warren Sandberg. Hello, Warren.
Hello, good to see you.
Warren is a professor of anesthesiology at the Department of Anesthesiology at Vanderbilt University Medical Center in Nashville. He's also the chief of staff of the Vanderbilt Hospital. And we know each other for a very, very long time. And we share our common interest in adding value for patient care. And we both explored at certain parts in our career that electronic data recording and the working with it is quite an important step in this endeavor. So, Warren, my first question is, you're working quite long in that field, and you was one of the first who was proponents of electronic data recording for a couple of reasons, not only for documentation. And as in Europe, we have a very heterogeneous situation. Some of us are working still on paper, some using different kinds of electronic patient data recording. Can you elaborate a bit about your journey in that field?
Sure. You give me credit for being an early proponent, but really the person who shaped my career was my former boss, the chair of the Department of Anesthesiology at Mass General, Warren Zapol, who, as part of his negotiations, become chair there in the 90s, included a requirement that MGH invest in electronic record keeping for anesthesiology. And the reason that he did that was to provide a searchable and readily available record, both for clinical use. I'll give you an example in a minute, but also to make sure that the department was able to fully capture the value of what it was doing. And in the United States, we're on a very much a pay-per-click model of reimbursement for healthcare. And so every activity that adds value to patients' course also generates revenue for the department. And every activity that you do that you don't record is an expense that you're not reimbursed for. And so Warren recognized very early, Zapol, that getting paid for what you were doing was easier if you had an electronic record to capture all of that and structure the data in a way that you could find it. And actually, one of my first publications in that space demonstrated that the department recognized real pickups in lost revenue that was lost because people didn't complete their documentation in a timely way, sufficient to actually pay for an additional anesthesiologist or at least keep that system in place forever. The real value, though, for a clinician is something I experienced last week. I was presented with a patient whose electronic record was marked very clearly right at the top when you open the page that they had a difficult airway. And we all know about the difficult airway who presents in a normal-looking patient. And the patient in front of me looked very normal. And so I opened their record and I looked for records of prior intubations and was able to discover that they had been intubated previously at Stanford University about 11 months before with a simple Macintosh laryngoscopy and a grade 1 view of the vocal cords. So the splash screen, which was really concerning, was actually in error. I was able to correct that and was able, without any effort whatsoever, to get a look at somebody else's record of that patient's care and avoid what could have been a real pain for that patient.
Yeah, I think that's a great example. And I think both parts of it, to have the information of the individual patient right away available,
Yep.
Is a very major step forward.
Well, in an integrated system now across, there are some systems that integrate across multiple hospitals independent of your network, right? Or in your case, of your country. So that is a real increase in leverage.
Yeah. After being in Nashville for a while, you implemented something I find very interesting. This is the anaesthesiology perioperative informatics department or sub-department, which is associated with a very active research group. Can you show or tell our people why you did that, why you made that decision together with the team?
So yeah, it's actually called the Vanderbilt Anesthesia Perioperative Informatics Research Group, VAPOR for short. And so VAPOR actually started off as the department's sort of local clinical informatics group to help us answer clinical informatics questions, some of the operational ones or related to finance, like the ones I just talked about for revenue. But over time, VAPOR has actually evolved into an institutional resource, and they are able to do data management to support one of Vanderbilt's calling cards, which is the hospital-wide fully implemented pragmatic trial. And so now VAPOR serves a function of data management for all kinds of patients who are having pragmatic trials that touch the perioperative space. And so they did the data management, for example, for several famous pragmatic trials, such as the SALT study, which basically compared normal saline to balanced crystalloid solutions for patients both admitted to the ED and also for patients in the ICUs, and demonstrated a clear difference between those two outcomes or those two interventions. And it's not widely appreciated that the data management and randomization for those trials were actually conducted by VAPOR. Yeah.
It's a great story, I think.
Can I have one more second?
Yes.
So we have there's a lot of interconnection here. I think you might talk a little bit later about our enhanced recovery programs, and we have turned our attention in VAPOR to doing pragmatic trials of various interventions in an enhanced recovery program and testing whether or not those individual interventions are necessary to achieve an ERAS outcome. And the results are not, for our most recent trial, were actually quite surprising. Can't really discuss them in detail, but they will show up in publication eventually. So we're now using the electronic record to both scaffold our pragmatic trials, and then the VAPOR group to do the data management and randomization in those trials. And we're coming back now with dispositive answers about things that people have argued about for a long time and felt to be an equipoise. So we're beginning to realize the real value both of the electronic record and the informatics group.
This is a very interesting part because yesterday we had a webinar about the use of routine data and big data in perioperative medicine. And I was allowed to give one of these talks. And I said that in our environment, the availability of electronic patient data from different sources allows us much better than earlier to answer the real world questions in anesthesia, which are impossible to get funded by a randomized controlled trial, and even impossible to be executed because you need enormous amount of patient records. And
Yes.
if I understood you right, the VAPOR group made that evolution quite naturally in the last years, starting from documentation, going over to business, and ending or now reaching also a very high research level.
Yes. Yes. Without actually any loss of function in those other areas.
Yeah.
Yeah.
Great. One very interesting part of it is that we are much more interested in following our patients for a longer time. And in my opinion, we need to do so because we never will learn about chronification of pain or value of interventions when we don't stay connected with our patients for 6 months, a year. How long does it take? You was a very early adapter of that part, and to my knowledge, since more than 10 years, you are following your patients quite on a regular basis. Can you elaborate a bit on that?
Yeah, gladly. Again, we were pushed in this direction partly by the exigencies of some of some of our regulatory framework in the United States. Just to come back to the enhanced recovery programs for a second, we actually track an outcome called Days Alive at Home 30-30, which I think is a metric that most of you are familiar with. And the reason we do this for a lot of reasons, but one of them relates to maintaining compliance with prohibitions on inducing patients to have medical care. So in the United States, we're limited to what we can give to a patient. Now, in our enhanced recovery bundles, we would like our patients to have good nutrition coming up to surgery and be able to use chlorhexidine wipes if that's indicated, for example. And that bundle of stuff costs a fair bit of money. And from an equity perspective, we felt it was necessary that every patient that we care for have access to that. It's not reimbursed in American insurance programs, and so some patients have to pay out of pocket for it, and not all patients can afford it. So we wanted to give it to them. So to demonstrate, to provide protection for ourselves against an inducement scheme, we had to demonstrate that giving these supplies to patients actually improve their outcomes. Yeah. And so because we have a great electronic system that captures all these data automatically, including the readmission, if there is one, measuring -30 was easy. We were measuring it constantly for everybody all the time. And we were also able to demonstrate very clearly that provision of this bundle improves -30 for patients. They spend more time alive at home than if we don't actually provide that bundle. And so we were able to make the case that it was good business, if you will, to give these things to patients, not as an inducement, but as an outcome improver. And it improved our financial outcomes too, because we don't get reimbursed for readmission within 30 days. And so by avoiding a readmission, we actually save money. This is all attributable to the fact that we've got really good data capture about our patients.
And it seems to me it's a classical example for adding value to the patient by staying connected with them and being interested in the patient's behavior.
Yes, yes. There are other examples of this ongoing connection. I think my favorite one is the patient portal to their own electronic record that we provide to them on their mobile devices. And I myself am a user. I'm a patient at Vanderbilt. And it is just the easiest way to transact business with your health system. And of course, your health system can reach out and transact business with you as well. And it not just business, it's the business of caring for the patient. And so we stay connected to our patients through that portal with everything from, wellness messages through to, hey, remember, you've got an appointment coming up in 3 months. Are you going to be there or not? It's a really good connection and very valuable. And again, the foundation is the electronic health record. Without that, you have nothing.
Yes, when listening to you, it seems that anesthesiology or anesthesiologists like us relatively attractive to organizing workflows, processes, with the quality of patient care in the center, but also with some view on the economical, technical, safety environment. Do you have any idea why we as anesthesiologists are so good in that?
I could talk for a while. I think it comes down to the nature of our primary environment, where we started, which is in operating room suites, right? So that is a shared space. It's a workspace for surgeons, but we are traditionally permanent denizens there. And our well-being as a specialty depends on the efficient management of that space in a way that is fair and even-handed. And so in the best circumstances, we wind up being seen as the honest brokers of access to the space, management of the space for the benefit of all the surgeons about the same, and all the patients as clearly as we can manage. Yeah. And when that's recognized in a health system, then whenever there is a space where an honest broker who doesn't, to use an American colloquialism, have a dog in the fight over territory, access to hospital beds or resources, but rather benefits from being a good steward of those resources, that's where you'll find anesthesiologists in leadership in enlightened organizations.
Hmm. I think also our interest in data and staying connecting is quite important because a couple of the not only the research group but also the standardized hospitality standardized hospital mortality rate groups are very interested in taking the patient in the center, but moving from there to bringing people together, feed them with the appropriate information in a digitized manner, and having the good discussions instead of having, let's say, a lot of emotional territory fights. I think this
Yeah.
is something we both can agree on.
Yes, yes, indeed. So we're thinking specifically about undesired events, individual events that lead to patient harm or patient injury, or in some cases death. We actually look for system level failures first and look for system level fixes for those. And again, the electronic medical record as a tool to trap and eliminate those opportunities for error is foundational. And so you could think of something like what I would call if-then conditional decision or clinical decision support. If the patient arrives in your hospital with an insulin pump, then you should mandate a consultation to the uh, endocrine service in the absence of an endocrine specialist on the admitting team, because the admitting team is unlikely to know the details of how to manage that pump. That's one use, right? So we can write a rule to actually make that happen in the electronic record, but then you can generalize that to all sorts of if-then conditions. If the patient has a positive blood culture, then you will mandate an infectious disease consultation. And this, again, it can be made automatic in the sense that the record keeping system will do that work and then present an option to the clinician. They don't have to accept the recommendation to have an endocrine consult, but if they choose to decline it, they're going to have to actually log that, and they in turn will be logged in when that happens.
Yeah.
So they're really great tools for managing performance.
Yeah, and I think we both agree these systems, in particular, when they comprise decision support, they are partners. They help us to use the adequate knowledge in our field appropriately. They are not concurrents, but they are just partners in looking for the best possible patient care.
Yes, yes. To continue on the if-then decision support, suppose let's talk about a baclofen pump instead, and you are a general internist admitting a patient with an unrelated problem. You might not recognize the patient has a baclofen pump.
Yes.
You might not, and if you don't take a good history, the patient might not tell you that. But in an interconnected electronic health system, the fact of that baclofen pump will be part of the patient's record. And so when you pass that admission milestone, that would activate the decision support, even if you as the clinician had missed the fact that this patient had this condition. But it can be a really helpful device.
As obvious, we normally start our video cast with an open question. I did that, and we close them with an open question. And at least in Europe, we have a lot of discussion about allowing systems to talk to each other, communicate, the pitfalls of digital systems. That's one thing. So I'm very much interested, and I'm sure our audience also. What's your vision? How can we design the next steps? A lot of buzzwords through the orbit, the use of artificial intelligence, the use of big data, and everything else. And I'm very much interested. What's your opinion on that?
That's a big open question. I think that I've always admired European governments for and organizations for their privacy concerns, especially. So in the United States, we are also very serious about privacy, but I think probably a little more promiscuous in the allowing data to flow back and forth. And I think that has led to real advantages in terms of our ability to know things about patients, and we assume that there's a beneficent intent. I think the assumption may not always be a correct one, but here up until now, apart from data breaches that have led to hacks and information being, sequestered, we haven't yet seen somebody get injured by the accidental sharing of data too much, but we have seen clear benefits of allowing that sharing. But I'm not exactly sure where we're going to go from here. I think we're capturing enough benefit now that if I were the person as the patient, I would want a more permissive sharing environment than what most people might accept. I think that the value to me of having my clinicians know everything about me outweighs any potential privacy risk. Of course, I've not been on the wrong side of one of those privacy problems, so I was speaking to you with a bit of a bias. I think going to the future, we are just beginning to see the opportunities to do these one-off decision support topics, right? I think, though, eventually the electronic health systems will have these features built in to their base systems, and we will come to take that for granted. And that will allow physicians and other healthcare providers to go from needing to remember and pay attention to fine detail and to monitor things that humans are not good at, and focus more on the human relations aspect of patient care and on noticing subtle abnormalities and changes in condition, things that humans are really well primed to do naturally, but that right now are being obscured by the need to take a very detailed history. Remember to make a checklist to do all these things, especially if you're in a paper record system. I would be really reluctant to move back to a system like that, knowing the advantages that we already experience and the potential that we could have.
Yeah, I think this is a very nice and evidence-based, I would like to say, look into the future, because I'm absolutely sure that all of us which are used to adequately use this electronic system, work with digitized data, able to make connections to patients, to other caregivers, which increase our role in the multidisciplinary treatment of patients significantly. This has really led to online execution of perioperative medicine. It's of just being part of the operating theater team, because at least in our country, anesthesiology is, let's say, one of the last holistic specialties in the hospital, overseeing a lot of patients flows, and having access to the majority of specialties in the meantime.
Yes. I would say that our department has had the journey of being an OR-based specialty to a broader hospital-based specialty, because the electronic health record has allowed us to prosecute these enhanced recovery protocols from the decision for surgery all the way through hospital discharge and beyond. And these are protocols that the development of them is actually hosted, convened by anesthesiologists with our surgeon stakeholders. But in fact, we are the glue that hold these programs together. And at my hospital, at least, these have become so important to the hospital's success that it is now a hospital-based initiative, with us not really so much in the lead as leading from behind, to take a phrase from Barack Obama. So orchestrating, but without being flamboyant about it. It's exactly the role that anesthesiologists play in our first environment, which is the operating room. It's been a real tool for us.
Yeah, and I think it also creates a lot of recognition. It increases self-confidence a lot, which is always good for a specialty like ours.
Yeah.
Baron, thank you very much for being with us, for us tonight, for you in the afternoon. And thank you everyone for listening to this episode of the European Society of Anesthesiology and Intensive Care Medicine podcast. Look on our website. We have a couple of very attractive other podcasts in our academic list. You can get them also via various other streaming portals. Warren, I hope to see you soon. I wish you a very good day, and goodbye.
Thank you. Goodbye.